Okay, good afternoon, everyone. I'm Bahab Jagafar, first-year fellow at Cleveland Clinic, Florida. Thank you for the opportunity, and thank you, Dr. Cohen, Dr. Placido, for your guidance. We'll be presenting a case of a transcatheter edge-to-edge repair for a mitral regurgitation secondary to a dehiscent valve ring. 75-year-old male patient. He has a cardiac history that is significant for coronary artery disease with CABG, with REMA to the OM and LEMA LAD, a subsequent PCI to the RCA. That was back, the CABG was in 2015, was associated as well with a mitral valve prolapse repair using a Sorin Memo 3D ring that is 30 millimeter. History of AFib, flutter with ablations, and heart failure with ischemic cardiomyopathy with reduced ejection fraction, other medical comorbidities including hypertension, dyslipidemia, thyroiditis, and renal cell carcinoma. The patient has been following up regularly in our heart failure clinic and has well had multiple hospitalization for recurrent heart failure exacerbation. And over the course of the 4 years, despite being on guideline-directed medical therapy and compliance with that, he had a reduction in his EF from 39% to 25%. Repeat workup including coronary angiography revealed stable coronary anatomy with no significant targets for revascularization. He had a transthoracic echo which revealed that he has a markedly dilated LV with severely decreased function, ejection fraction 25%, and it showed that there is the mitral valve repair with a ring and concern for ring dehiscence with a moderately severe eccentric intramedia directed mitral regurgitation based on the Quanda effect as well. Here, as we can see on the transthoracic echo. And this is for the short axis as well. For the sake of time, we'll keep going. Transesophageal echocardiogram confirmed that there's a dehiscence of the mitral valve ring with the presence of mitral regurgitation, as we can see here on the photo as well, whether the 3D or the biplane photos. Same findings as well confirmed. The EROA was 0.63 centimeter squared and confirmed that the anteriorly directed mitral regurgitation jet originating along the medial aspect of the coaptation line. He had a right heart catheterization that revealed evidence of pulmonary hypertension in addition to elevated wedge pressure with a V wave all the way up to 36 millimeter mercury with borderline cardiac index. At that point, the heart team had multidisciplinary team discussions, and he was deemed to be high risk for a surgical approach given his comorbidities, and the decision was made at that point to proceed with edge-to-edge repair transcatheter. One of the points as well that came out, why wouldn't he be a candidate for like a valve and ring, but unfortunately due to the nature of the ring he had, that was not an option. So discussions went up about which clip or which edge to repair to use, whether it's the Mitra clip versus the Pascal ACE, and eventually the decision was made to go with Pascal ACE for those advantages: the independent leaflet attachment, central spacer, board paddles, and elongation of the device that will allow safer maneuvering, especially that the patient's mitral regurgitation was more near the commissure in a crowded area that was going to be challenging to navigate with a Mitra clip while it's open. That was the structural planning, saying that probably he would need one clip, ACE clip, maybe two as well. So we'll skip through that. The procedure was done through a transseptal approach. One of the things as well, that because of the location of the ring and the posterior dehiscence, there was a challenge trying to be having the transseptal approach as anterior as possible, like in an aorta-hugger pattern, to try to puncture the septum anterior to be able to deploy the clip or the Pascal ACE in a favorable spot. And as we can see here, the clip being deployed. So, and we'll see here the results before and after. So on the left here, you can see the results before deployment of the clip as compared to the right here after deployment of the clip. And we can see significant reduction in the mitral regurgitation. Did not totally resolve, but went from about 3+, 4+ to 1+ mitral regurgitation. Same for the images here on the biplane views as well, compared side to side. And as well, that was confirmed on the transthoracic echocardiogram the following day with significant reduction in the mitral regurgitation. In regards to the hemodynamics as well inside the cath lab, it was noted that there was a significant reduction in the V wave from high 30s all the way to low 20s for the V waves, and the mean dropped as well from 20s to around 12 millimeter mercury. The procedure results compared to before and after the mitral regurgitation severity, as we mentioned, went from 4+ to 1+. The transmitral valve gradient did not change. There was a change in the pulmonary vein flow pattern. Before was a blunted S wave, and then there was a prominent S wave and V wave. Left atrial pressure, as we discussed, changed, dropped the peak from 40 to 27 and the mean from 22 to 17. The effective regurgitant orifice dropped from 0.61 to 0.28. Regarding the clinical course of the patient still follows up regularly in the heart failure clinic. He reports improvement of his symptoms post-procedure, although he says that he did not totally feel like much better in exercising, but he attributed that to deconditioning. But he's able to climb 2 flights of stairs as compared to before the procedure, where he was able only to complete one, and he has not had a single hospitalization since then. And follow-up cardiogram repeated at 6 months confirmed the same thing. Some takeaway points, as we know, the prevalence of the mitral regurgitation dehiscence is very rare and around 1.6%. However, once that happens, it carries the risk of subsequent heart failure, as in our patient, endocarditis, and increased mortality. Transcatheter edge-to-edge repair can be safely utilized in failed surgical valve repair. And the last point to bring that, as comparison MitraClip and Pascal, we know that both are effective for regular patients or patients with mitral regurgitation in general, but maybe in patients with dehiscent ring, Pascal can be more favorable in that condition.